to Rachel Melson, who's the Outreach Clinical Director for the Swope Health Clinic in Kansas City, Missouri. We're talking about extending hepatitis C testing and care to persons experiencing homelessness. Rachel.
Great, thank you so much. So hello, everyone. My name again, it's Rachel Melson. I'm the Outreach Clinic Director at Swope Health. Swope Health is the largest FQHC in the Kansas City area, and we've been providing care to an underserved community for over 50 years. Today, I want to share with you how we provide testing and treatment for hepatitis C for people experiencing homelessness. We do that through a flexible, community-based model that integrates screening, treatment, and partnership so we can best meet patients where they are. So I start just about every presentation I give on hepatitis C and our program at Swope Health with this slide. I love it because we don't get to use the word cure much in medicine, but as we all know, we have a cure for hepatitis C. The problem is so many people don't know their status and can't access treatment. Each year, over 15,000 people die from hepatitis C-related illnesses, and unfortunately, people experiencing homelessness are disproportionately affected. It's been hard to estimate how much Hep C truly impacts the unhoused community in the United States. Studies have varied and shown it's anywhere from as low as 9% to as high as 60%. There's a really interesting study that was done in Los Angeles on Skid Row, where they found that around 26.7% of adults experiencing homelessness were impacted by hepatitis C. And at 26.7%, that's more than 10 times that kind of 2% overall rate that we see in the general population. More surprisingly, less than 3% of those persons had actually ever had access to treatment. Closing this gap is essential for any local, state, national, or even global elimination efforts. So why are people experiencing homelessness so disproportionately impacted? Well, it's because hepatitis C, as we know, doesn't exist in isolation. It's a part of a syndemic where Hep C overlaps with housing instability, substance use, mental health conditions, and even risk for other diseases like HIV. And then all of that is layered with, other social determinants, other health conditions that each of these individuals may face when accessing healthcare. So these challenges reinforce each other, and our care models have to address all of them together to really be effective. We have to focus on integrated and flexible and community-based care models that address multiple needs often at once. So again, our patients face these barriers and layers, right? So the most significant are those competing priorities for just survival. We have structural barriers that include systems that have like siloed health and housing and harm reduction services. We have structural barriers that created a deep-rooted mistrust from the trauma that happens when accessing a healthcare system. And then that's further layered with stigma. Finally, we have tons of policy barriers that I could spend another hour talking to all of you about. But we have sobriety requirements and restrictive provider requirements, and these keep patients from accessing a streamlined opportunity for care. So at Swope Health in our outreach clinic, we provide holistic medical care at shelters, transitional living facilities, halfway houses, domestic violence centers, and directly on the streets through our mobile medical unit, which you can see on the picture here. In that unit, we offer for every patient an opt-out model of hepatitis C and HIV testing, and we integrate our hepatitis C treatment into our overall primary care services. All of the providers in my clinic are not only equipped as primary care providers, we all provide hepatitis C testing and treatment services. We started our hepatitis C treatment program in 2019, and I am so proud to share that since that time, we've helped almost 700 patients access treatment for hepatitis C. So our success really depends on our community partnerships. Partnering with the local shelters and street medicine teams and resource hubs has helped us tremendously. And consistency has been key for us, not only just with our partners, but with our patients, showing up in the community over and over again when we say we're going to be there. We also emphasize opt-out testing to try and remove the stigma from knowing your status of hepatitis C and HIV. We integrate our care with chronic disease management and harm reduction. You want to make the most out of every visit when patients are accessing their healthcare. And sometimes that means creating a more holistic and integrated approach. Flexibility is one of the most important considerations when providing care in this population. Imagine the city bus is your only mode of transportation, and now it's running late, and now you're 2 hours late for an appointment. Now, what are you going to do? Being open to things such as late arrivals, allowing for walk-ins, even converting visits to telemedicine visits are all ways that you can help meet your patients where they are. Something else that has really helped us is simplifying the process for patients in accessing medications. Most barriers in healthcare really compound on each other. You hit a roadblock after roadblock and you start getting discouraged. We want to give our patients the illusion of ease. Even if we know the prior authorization process isn't something that's going to be easy for us, we want to make it seem like it is for our patients. We want to let them know that we've got this and all they have to do is show up and take their medication. The goal here is truly like a low barrier access to care. So I wanted to highlight how we provide this care with just a few examples that I've had in my clinic setting. So here we have a 22-year-old man who regularly sleeps outside, and he approached our mobile medical unit at one of our regular Thursday morning locations. And so he presented because he wanted help with his daily fentanyl use. In my discussion with him, he was very comfortable with the resources available and knowledgeable of the city bus system, but he absolutely did not want to walk in the walls of our brick and mortar clinic site. And so we, in that moment, we provided point of care testing for him. He tested positive for hepatitis C. At that time, he was negative for HIV. So how did we meet his needs? In that moment, we decided to do a lab draw on our MMU. That's what we call our mobile medical unit. We discussed Suboxone services and MAT and what that would look like with his current fentanyl use. And, we discussed opportunities for HIV prevention through PrEP. We encouraged him to continue to come see us every week on our mobile medical unit, again, at that spot that we routinely go to on Thursday mornings. And, because we chose this kind of flexibility, this low barrier approach, this patient now walks around with naloxone in his pocket. He has continued to follow up with us. He actually comes to see us still, even after he's completed treatment. Every Thursday morning, he comes to say hi to us at this location. He's no longer using fentanyl. And he's still, to this day, this was a couple years ago, he's still on HIV PrEP. We've engaged him into a recovery program, and he's doing really well. This was all done without walking into the doors of our clinic building. We, again, opted to create this kind of coordinated and patient-centered kind of tailored approach to his care because that's what he needed in that moment. So just another quick example of a patient that we saw over the last couple of years, a 58-year-old man. He was engaged in treatment, came onto our mobile medical unit while we were on site at the shelter providing medical services. This was somebody who had attempted to try and get treatment in the past, but had been lost to follow up after getting his first box of medication. He never took more than a week. When he came onto the mobile medical unit, he was ready. He was engaged. He was really excited about being in the shelter. He was going to be starting a program with them. So we opted to go ahead and start him on some medication that day. And we scheduled him to come into the clinic for a 4-week follow-up. And of course, unfortunately, he did not come to that scheduled appointment. So what did we do? We have, a really great partnership with the shelter and a MOU for our care coordination. And so we were able to reach back out to him through the shelter because we had seen him there. We knew that he was staying there. Our Hep C nurse partnered with the shelter's medical coordinator and arranged a walk-in visit for the next day. And then we just followed through with him and ensured he completed the treatment and he achieved a cure. Now that success was possible because of that strong community collaboration that we had. So what has worked for us overall? It's really creating processes that encourage meeting people where they are, both literally and figuratively. You really have to get to know your community and the resources they have available. Where do your patients go to eat, to sleep, to shower, to get meals? You want to create partnerships with those locations and be visible in the community. This will not only help you build trust and rapport with patients in the community over time, it will show consistency so that you can lean on your community partners when you need to help really coordinate that patient care. And we also learned that we need to be flexible, again, creating opportunities for low barrier healthcare access. Now, I will be the first one to tell you I'm very type A. I love my routine. I love my schedules. And working with this population of patients has really challenged me as a person because you really have to be flexible. You have to, know how to adapt in the moment because that's what your patient population needs. Community-based models can really close gaps in hepatitis C care for persons experiencing homelessness. And again, the core ingredients of this are creating those partnerships, flexibility, and trust. A couple years ago with the National Healthcare for the Homeless Council and NVHR, we created this hepatitis C provider pocket guide. It was created to help support clinicians in working in this population with screening and prevention and treatment. It does, as a disclaimer, need a little bit of updating for some of the newer guidelines, simplified guidelines from the AASLD and ISDA, but I can provide a link to this in the chat if any of you are interested. Again, I want to thank everybody for the opportunity to share our work on this topic. I tried to get through it as fast as possible, but I love talking about not only providing this kind of care in populations of persons who are experiencing homelessness, but talking about hepatitis C testing and treatment. Feel free to reach out to me if you have any questions.
Thank you so much, Rachel. That is fantastic. It's a remarkable 700 people treated for hepatitis C. What a great accomplishment.
Thank you.
Population is really, challenging, as you made evident. That's just really, really a big achievement. So I just want to extend my thank you and congratulations to you for that. And you sort of began to reveal how you made that happen. So thank you.